Good morning, everyone. This is Jerry Gleich speaking, and I am one of the moderators this morning to assist you with the information that will be presented. As you can see, you are on the International Eosinophil Society webinar, and today we're discussing the hypereosinophilic syndrome overview and unmet needs. You should be aware that we have simultaneous translations into German and Japanese, and the access to these should be at the bottom of your algorithm, and it's under interpretation. It may be obscured, and you may have to press more, the three little dots in the circle, to bring out the interpretation. About the International Eosinophil Society, I remember vividly a meeting now, oh my gosh, it must be almost 30 years ago, of a group of us in Lund, Sweden, after a lengthy day meeting, deciding that we needed a society. And so the society is an organization of scientists and clinicians who are interested and perplexed and intrigued by the eosinophil, because the eosinophil has many, many modes and even many shades, if you will. So what does the society do? It sponsors biennial meetings, monthly webinars, and these have been excellent. I can't emphasize too greatly the importance. Other educational program for the members to review new information about the eosinophil and its roles in health and disease. And to join, you can focus on the diagram there, join the HES, and that will allow you to gain access to membership activities, membership enrollment activities, I should say. And the free membership is open to predoctoral individuals, as well as those in postdoctoral programs, clinical fellowships, and residency programs. So we have a big family here. Okay, and here, look at that. And Vancouver's getting hit by a stream of moisture right now. So you'll see the biggest trees you've ever seen in Vancouver. But on the 12th to 16th of July next year, when we have our 14th Congress, it's going to be wonderful. Airline travels are going to be simple, and we're all looking forward to getting together, even some of us who have handicaps. And this, though, is the next important outlook for you, and that is the next IES and the joint webinar on the 14th of January, and the different time zones are listed there, from infection and stress to allergy roles of eosinophils and mast cells. So expect to see you all with our speakers. And last but not least, it's important to thank AstraZeneca for their generous support of the webinars and those activities. I think I can hold there and pass it on to my co-moderator, Dr. Constantine.
Yeah, thank you, Dr. Gleich. So I'm your co-moderator today. My name is Greg Constantine. I'm going to just go over a few housekeeping things for those of you who may be joining a little bit late. As a reminder, we have simultaneous German and Japanese translation available today's webinar. To be able to access those translations, you go to the bottom of your Zoom window. You'll see an interpretation tab. It looks like a little globe. If you don't see that, it may be hidden under the More button. So if you just click the More button and then select interpretation, you'll be able to have that option. Some other housekeeping items for today's webinar. So everyone will be muted, all attendees, and the chat feature will be disabled. If you have a question or a comment to ask during the presentation, feel free to do so at any time. Myself and the other moderator, Dr. Gleich, and the hosts of today's webinar will be monitoring both the question and answer window to be able to make sure that your comments are addressed. The webinar is being recorded and will be posted to the IES website shortly after today's webinar. And for those of you who would like to use closed captioning or live transcription during the webinar, you can do so by clicking the Show Caption button, which is also found at the bottom of the Zoom window right there. So we have an excellent and exciting webinar planned for you today. We have Dr. Florence Roufosse, who will be talking about an overview of hypereosinophilic syndrome, Dr. Amy Klion, who will discuss unmet needs related to HES, and Dr. Anna Kovalszki, who will be discussing diagnostic and therapeutic patient journey. So with that, it's my privilege to introduce our first speaker today. Dr. Florence Roufosse is a professor of medicine, internist, and clinical immunologist at CUB Hospital Erasmus in Brussels and is the past president of the International Eosinophil Society. She's in charge of a specialized consultation dedicated to diagnosing and treating eosinophil-related conditions that is integrated in the European reference network, EuroBloodNet. She also manages patients with systemic autoimmune and autoinflammatory conditions. Besides her clinical activities, Dr. Roufosse also leads a translational research projects to improve understanding and treatment of lymphocyte variant HES and participates in international research efforts to better delineate disease course and treatment responses of HES. She's involved in the design and conduct of international clinical trials evaluating the efficacy of novel treatment options in patients with HES and eosinophilic granulomatosis with polyangiitis, EGPA, as well as sub-studies that aim to identify biomarkers and/or disease variants predicting treatment responses. So with that, I'm happy to turn it over to Dr. Roufosse, who will be going over an overview of HES.
Thanks a lot, Gregory, for your kind introduction and your kind words. I'm first going to share my slides, put them on full screen. I hope everyone sees my slides. Is that okay?
Looks good.
So, thank you. So I'm going to be talking about hypereosinophilic syndrome to begin this webinar. And it's really a privilege and a pleasure. I think these are really happy days for those of us who take care of these patients. I'm going to begin, first of all, with my disclosures and also with a few very basic and simple slides, because I think that the participants to this webinar are from all sorts of horizons. So just to bring up to speed, I'm going to give just 2 slides about the basic eosinophil biology. So eosinophils are cells that derive from the bone marrow. These are cells that belong to the myeloid lineage. They develop under the impact of a series of transcription and growth factors, and we'll come back to that later, but interleukin-5 is really an important factor involved in eosinophilic poiesis, and as we'll see, other aspects of the life cycle of eosinophils. Eosinophils will then transit into the blood, where they don't stay very long, and they're not very numerous. You can see that they represent typically less than 5% of white blood cells, and they have a strong tendency to migrate into tissues. And at the bottom of this slide, and I'm going to perhaps activate a pointer here, if I can, at the bottom of this slide, sorry, up. There we go. You can see the different tissues where typically we will find eosinophils in healthy individuals. The location where you find really the largest pool of eosinophils is in the gastrointestinal tract, with the exception of the esophagus, which is normally devoid of eosinophils in healthy individuals. Eosinophils are very complex cells. These are granulocytes. They contain different granules, different shapes and sizes. These granules contain a series of molecules that have very, very different functions. Among these molecules, some are very well known. These are the cationic proteins like major basic protein, eosinophil peroxidase, eosinophil cationic protein, and eosinophil-derived neurotoxin. But as you can see, they also produce numerous cytokines, growth factors, chemokines, as well as enzymes, some of which are similar to those produced by neutrophils. Eosinophils also have lipid bodies, which contain these arachidinic acid-derived mediators that you can see here that will also participate in eosinophil effector functions. And then finally, eosinophils also contain a molecule, galectin-10, which when it's released into the extracellular environment is going to crystallize to form Charcot-Leyden crystals. And the presence of Charcot-Leyden crystals in a biological fluid really signs the recent presence of eosinophils that have been activated and that have released their granules and this protein. So these are cells which have a highly cytotoxic potential, and this can be illustrated by the two following slides. This is a very nice old study, but I like to show it because it really shows the toxicity that eosinophils will display on endothelial cells. And what you see here is the papillary muscle from the heart of a cat that's incubated in medium alone or in the supernatant of healthy eosinophils from a healthy subject. And you can see a very, very nice intact endothelial surface. Whereas if the same endothelial surface is incubated with eosinophils or the supernatant of eosinophils that have been taken from a patient with hypereosinophilic syndrome, and that's today's topic, you can see a very, very different picture with clearly there's damage that's being incurred here on the endothelial surface. This was in vitro in a very old study. It's a cat. But this also happens in human beings in vivo. And so what you see here is just one example of the different complications one can see in patients with hypereosinophilic syndrome. You can see massive infiltration of the subendocardial layer here by eosinophils. And these infiltrates, if they are durable, will eventually lead to subendocardial fibrosis. And there's really marked cytotoxicity. And we recently published a case report in a patient who had sustained hypereosinophilia in the context of a hypereosinophilic syndrome. This was lymphoid variant hypereosinophilic syndrome, who developed what's called cauliflower aneurysms here at the basis of the aortic arch. And with the help of Gerald Gleich and his team, although routine hematoxylin eosin staining showed absolutely no eosinophils in this tissue, we were able to show that there had been presence of eosinophils with intact eosinophils plus free granules in this aortic arch. So hypereosinophilia is important to define before talking about what a hypereosinophilic syndrome is. Hypereosinophilia can be defined in the blood and in tissue. In the blood, it's defined as more than 1,500 per microliter at least twice, with at least a minimum interval of 2 weeks. And the hypereosinophilia in tissue, as you can see, has different potential definitions. You can define it on the basis of the bone marrow eosinophils being more than 20%. The pathologist opinion that there are too many eosinophils compared to what we expect in a given tissue. And finally, and this is perhaps the most interesting and intriguing definition, is that even if you don't see eosinophils, like the case report that I just showed you, if you can demonstrate the recent presence of eosinophils by the presence of eosinophil granule proteins, this qualifies for the existence of hypereosinophilia in the tissue. And this is just one of many examples taken from the literature where you can see that although there's very, very little presence of eosinophils as assessed by a routine stain, you can see that this tissue is actually painted with major basic protein, which signs the presence of activated eosinophils and therefore tissue hypereosinophilia. Now, moving on to hypereosinophilic syndrome. To be able to qualify for this disease, you have to have both blood and tissue hypereosinophilia, and the organ damage which is associated with this disease has to be associated and mediated by the presence of eosinophils in the tissue, with exclusion of other disorders that could eventually drive this damage. This slide kind of summarizes the different forms of organ damage and clinical manifestations that one can encounter in patients with hypereosinophilic syndrome. I've made boxes around the 3 organs and tissues where you can find complications in the highest percentage of patients with hypereosinophilic syndrome. These are actually all tissues with which we are in contact with our environment. It's the skin, the gastrointestinal tract, and the lungs. And you can see that the complications take many, many different forms in these organs. You can also see from this slide that practically no organs are spared in patients with hypereosinophilic syndrome. And from one patient to the other, the nature of the organs involved will vary in a given patient and over time. I'd also just like to underline the cardiac manifestations. I already illustrated this with one slide, showing that you can have subendocardial fibrosis. There are also cases with more acute forms of myocarditis. Patients can also have entrapment and even destruction of the valves. This is less common, eventually occurs in 1 out of 5 patients with a hypereosinophilic syndrome, but it is certainly what causes the most morbidity and mortality in this patient population. Hypereosinophilic syndrome can arise in different circumstances. The pathogenesis, which is actually driving the expansion of the eosinophil lineage, there are several mechanisms which have been revealed and described. The first, it's certainly not the most common, it's the presence of a somatic mutation which is driving clonal eosinophil expansion. Second mechanism, which has been described, is the overproduction of eosinophilic poietic cytokines, namely IL-5, and I'll go into this with a bit more detail in a few slides. Very, very rarely, there are several families where hypereosinophilia has been described, and I will not be discussing that today because it's really been described in a very, very small number of families so far. And in the majority of patients, as we'll see, the etiology of eosinophil expansion remains completely unknown. To illustrate one form of clonal eosinophil expansion, I'm just going to describe the FIP1-like1 PGF receptor alpha fusion gene. So this is a rearrangement which occurs as a result of an interstitial deletion of only 800 kilobases on chromosome 4. 800 kilobases. This cannot be seen on a karyotype. So it's a cryptic rearrangement leading to the fusion of these two genes. The fusion protein has autonomous tyrosine kinase activity, leading to clonal eosinophil expansion, and this is classified among the myeloid lymphoid neoplasms with eosinophilia and rearrangement of these different tyrosine kinases that you can see here. Clinically, this variant has to be suspected in presence of male gender, elevated serum vitamin B12 and or tryptase levels. Patients often have an enlarged spleen, although these are not gigantic spleens. These are often spleens which will be revealed more by imaging studies than by the clinical evaluation. And perhaps a very important point is the fact that these patients rarely respond to a challenge with corticosteroids. And the diagnosis can be reached using a PCR, looking for the fusion, as well as by FISH, looking for a locus which is deleted because it's between the two genes which will be fused. This is not common. I'd like to insist on that point. So it's certainly not the first thing that comes to mind when you're confronted with a patient who has a hypereosinophilia. I'd also like to mention this recent study, which is very interesting because beyond these rearrangements, there are increasing numbers of mutations that have been described now in association with hypereosinophilic syndrome. This is a very nice recent study looking at 64 patients who had a hypereosinophilic syndrome and some features clinically and biologically suggesting that they could have a myeloid neoplasm. And I'd like to underline here that many of these patients, you can see here the little R's, were corticosteroid resistant, just like what I mentioned for the FIP1-like1 rearrangement. And what was shown in this study by next generation sequencing was that there were many patients, 3/4 of patients actually had detectable mutations. And you can see that many of these mutations, this is half of the patients in the study, had mutations involving the JAK-STAT molecules that are shown here, STAT5B, 5A, etc. And I'll say in passing that many of these mutations were actually associated with mutations that are already known in myodysplasia. So this is the clonal hematopoiesis that you can see here. Clinically, many of these patients have a slightly increased spleen as well, and you can see that these are the myeloproliferative features which were seen. Lymphoid variant hypereosinophilic syndrome. Here, the cell which is primarily ill is not the eosinophil, it's the lymphocytes. And what you can see here in this lymphocyte phenotyping study is the presence of these pink cells. So they're CD4 positive, but they don't express the CD3 antigen on their surface. And these cells have the ability, when they're stimulated in vitro, to produce large amounts of IL-5. And this is what is driving polyclonal eosinophil proliferation. The percent of these cells may be really, really low, so it's important to be very, very careful when analyzing the T cell flow, the phenotyping of lymphocytes in patients. And the TCR gene rearrangement pattern is always monoclonal. If you go up to if when there are very few cells, you won't necessarily be picking that up on whole blood, but if you purify the cells systematically, they will be monoclonal. This variant has to be suspected in presence of predominant cutaneous manifestations. Clinically, the patients often present with angioedema and or underlying fasciitis, and they often have a serum hypergammaglobulinemia. And the diagnosis will be reached, as shown here, by lymphocyte phenotyping, the looking for clonal TCR gene rearrangement patterns, and there's a very nice serum biomarker which is extremely sensitive, a bit less specific, which is elevated serum CCL17 or TARC. I'd just like to mention in passing a specific variant of hypereosinophilia, which is tissue or organ-restricted hypereosinophilic syndrome. In this particular variant, there is tissue hypereosinophilia, but the criteria for blood hypereosinophilia is not fulfilled. And just to give one example, one illustration, idiopathic chronic eosinophilic pneumonia, can fall into this category. So these are patients who recurrently will present with breathlessness. If you do imaging, you're going to see condensations, ground glass opacities. If you do bowel fluid analysis, it's packed with eosinophils, and biopsies will show the presence of massive amounts of eosinophils, both in the alveoli and in the interstitium. These patients often have increased blood eosinophil counts, but they're not necessarily above 1,500. And these are the patients who we will qualify as having a tissue-restricted hypereosinophilic syndrome. The same patient could also have 5,000 eosinophils in peripheral blood, and then will be called proper hypereosinophilic syndrome. The variants can be classified according to pathogenesis, so what's driving the hypereosinophilia, or on the basis of the clinical manifestation. And this is really my take on how to classify patients. So we discussed the myeloid and the lymphoid variants. I showed you the two most common subvariants, but it's important also to know that other tyrosine kinase genes can be rearranged. There are also point mutations, I already discussed that, and patients who have constellations of myeloproliferative features should probably be considered as having myeloid variant HES. Same thing for lymphoid variant, other abnormal phenotypes have been described. But at the end of the day, what you see on the right-hand part of the slide is the majority of patients, roughly 3/4, the actual underlying mechanism driving hypereosinophilia remains unknown. Another way of looking at the classification is looking at the clinical presentation. So some patients have organ-restricted disease, and they're always going to have recurrence only in this organ. Others have multi-organ disease, and others have very, very specific kind of caricatural disease presentations, like, for example, patients who have episodic angioedema with eosinophilia. And we could also perhaps put as a particular clinical manifestation patients who have this overlap form of ANCA-negative EGPA with upper and lower respiratory tract perturbations and systemic complications due to hypereosinophilia. And if you look at these two different classification patterns, there's clearly some overlap. Any of these boxes can go one to the other, with sometimes perhaps some of these arrows are a bit thicker. For example, in patients with episodic angioedema with eosinophilia, it's really important to carefully check if they don't have lymphoid variant HES, because this variant is particularly common in patients with that clinical presentation. Classical treatment options will be dependent on the disease variant. Very clearly, patients who have myeloid HES with the FIP1-like 1 rearrangement, their first-line treatment is going to be Gleich, imatinib mesylate, with excellent treatment responses, very, very rapid responses to very low doses, as you can see. So this is associated with very, very little toxicity. Patients who have these myeloid disease features, who have other rearrangements, overall, I'm not going to go into any detail on this particular disease presentation. Hematologist referral is really important, either to include them in a clinical trial or to initiate targeted treatment. In all other patients, so those with idiopathic lymphoid variant hypereosinophilic syndrome, but even those who have some degree of myeloproliferative features, first-line treatment is generally going to be corticosteroids, and the majority of patients are going to respond. The problem is going to be when you're going to try to reduce the corticosteroid dosing, you may be seeing recurrence of symptoms, and these patients are often corticosteroid dependent. That's why we need second-line treatment options, and until relatively recently, we were kind of stuck with treatments that were very historical, because these were treatments that were used for chronic myeloid leukemia with relatively poor treatment responses and or poor tolerance, which means that roughly 3/4 of patients, at least, who were given these treatments were actually at the end of the day, these treatments had to be withdrawn, either for tolerance or lack of efficacy. So obviously, eosinophils are an interesting target as they're driving damage in these patients. We can target eosinophils in one of two ways, either by starving them of the cytokine that they crave for their survival and activation and proliferation, or by killing them directly with antibodies directed against the receptor. And benralizumab is one example that will then recruit killer cells to kill the eosinophils. Whereas here, eosinophils, as I said, with mepolizumab or reslizumab, are going to be more starved of IL-5 and will therefore also eventually be reduced in number and activation status. So this clinical trial that was published several years ago now has led to approval of mepolizumab for treatment of hypereosinophilic syndrome. You can see that the dosing is higher than that's used for asthma. And in this trial, patients were entered at a time that their hypereosinophilic syndrome was uncontrolled. They had to have at least 1,000 eosinophils, at least 2 flares in the preceding 12 months. These were obviously FIP1-like-1 PDHF receptor alpha negative hypereosinophilic syndrome patients, and their background therapy had to be stable. And in this trial, patients were randomized to receive either mepolizumab or placebo for 32 weeks, and the primary endpoint was the proportion of patients who were going to experience a flare during this period. The trial met its endpoint. There was a 50% reduction in the proportion of patients who flared. As you can see here, the cumulative number of flares was a lot lower in patients who were receiving active treatment. And when the flare rate was annualized, you can see a 66% reduction in the flare rate in these patients. So this trial was a success, led to approval of mepolizumab for hypereosinophilic syndrome. And so the practical approach to treatment nowadays is, once you've seen that patients are corticosteroid responsive and you're trying to lower corticosteroid dosing, probably you should start thinking already of eosinophil targeted therapy as soon as reasonably possible, and obviously on the basis of best clinical judgment with respect to other potential underlying differential diagnoses. Another interesting treatment option, for which we have a lot less data, but there's accumulating data right now, is JAK inhibitors. I don't have much time to go into this in detail, but there are some nice small case series showing efficacy of tofacitinib and or ruxolitinib in patients who have lymphoid variant hypereosinophilic syndrome, which can be a very, very refractory disease form, including lack of response to eosinophil targeted therapy. So this is becoming an interesting alternative for patients with lymphoid HES. And there is also, and based on what I showed you with the percentage of patients who have myeloproliferative features and who actually have mutations in the JAK and the STAT pathways, JAK inhibitors, in particular ruxolitinib, are very interesting for patients who have suspected myeloid variant forms of hypereosinophilic syndrome. There's currently an ongoing clinical trial, NATRON. This is a clinical trial investigating benralizumab, 30 milligrams every 4 weeks for HES. This is an increased frequency of dosing compared to the asthma dose. This trial was initiated on the basis of a pilot study that studied responses in 20 patients with HES to benralizumab, and it was published by Amy Klion's group several years ago, which reached its primary endpoint in terms of the efficacy on eosinophil counts in these patients, but also clearly showed clinical efficacy as well. So in this recent randomized clinical trial, patients were randomized to receive either benralizumab or placebo for a period of 24 weeks. And the primary endpoint was the time to the first hypereosinophilic syndrome flare. Patients were then all shifted into an open label extension, looking at all of patients receiving benralizumab and looking at treatment responses. You can see that the eligibility criteria were pretty similar to those in the clinical trial evaluating mepolizumab, and the results of the first part of the trial will soon be presented. They have not yet been published. So the take-home messages of this presentation are summarized here. Hypereosinophilic syndromes share eosinophil-mediated damage that can affect one or several organs in a given patient. The pathogenic mechanisms vary. They can be either clonal eosinophil expansion, but also this can be T-cell driven. This only accounts roughly for 1/4 of cases, so the majority of patients have unknown disease-driving mechanisms. If in presence of corticosteroid resistance, you should definitely consider doing next generation sequencing, looking for these JAK-STAT mutations that I mentioned. T-cell phenotyping can be tricky in patients in whom you suspect hypereosinophilic syndrome lymphoid variant, because the contingents of abnormal T cells can be very, very small. Targeting eosinophils is an effective means for many patients for controlling disease activity and reducing background corticosteroids, especially in those with idiopathic hypereosinophilic syndrome, whereas JAK inhibitors show promise for the other lymphoid and myeloid disease variants. The therapeutic landscape has changed a lot. This has improved patient outcomes outstandingly in many, many cases, but we still have much to learn about the pathogenesis to further improve outcomes, and we'll be hearing about these unmet needs in the next presentation that will be given by Amy Klion. I'd like to thank you for your attention, and am ready to take any questions on this topic. I don't know if, Gregory, are you going to be asking me or
Yes. Yes. So we have a very interesting question from Kelly McNagny. She says she's curious about lymphoid variant HES. Is it possible that the lymphocytes that are seen could be actually ILC2s? They frequently see ILC2s out of frame with TCR rearrangements. And of course, it's important to point out that ILC2s live in the bone marrow, where they can prime eosinophils by expansion of production of IL-5. Might fit with the low percentage of cells that is seen.
Okay, so these seem to be legitimate CD4 T cells, which have then lost their CD3 TCR chains on the surface. They actually continue to express the majority of the CD3 and TCR chains in the cytoplasm. They have markers which are quite characteristic of CD4 T cells, which you would not find on ILC2s. I mean, the question is certainly interesting. Perhaps there are interactions with ILC2s in patients such as these, but the characteristics really qualify them as being legitimate CD4 T cells.
Great. Steve Ackerman asks, what percentage of the 75% of idiopathic HES patients are responsive to anti-IL-5 biologics? And what is the source of IL-5 in these patients?
So if the source of IL-5 was known, we'd probably no longer be calling them idiopathic, and maybe we'd be putting them in another category, the lymphoid category. So, I mean, there's much reason to believe that in many of these patients, at the end of the day, it's going to be T cells that are driving the eosinophil expansion through production of IL-5, but that really remains to be well demonstrated. In terms of the percentage of patients with idiopathic HES which respond, it's kind of difficult to really give a precise number, because the studies that have been conducted so far were a mix of patients who had lymphoid and idiopathic HES, because the patients that were, and maybe even some myeloid variants, because the only patients that have been excluded from the trials are those with FIP1-like1 PDGF receptor alpha rearrangements. So, I mean, it's difficult to give a precise answer, but it looks like, I mean, certainly more than half of patients respond well. There are some super responders, so patients who have predominantly pulmonary manifestations. These are really super responders, and I would think that patients who have chronic eosinophilic pneumonia, for example, response rate must be 100% overall. Whereas patients who have more predominant cutaneous manifestations, the response rates seem to be lower. So it's quite heterogeneous. There's probably referral bias depending on what a given center is going to be recruiting in terms of the type of patients and the nature of complications. But overall, it seems to be above 50%.
I have another interesting question from Mark Rothenberg. He says, can you speculate on the causes of LHES idiopathic HES, and why IL-5 is typically not elevated in most HES patients in the serum?
So I think that, as was the case, by the way, for eosinophilic esophagitis, I think we haven't been looking at the right place for a long time. I think we have to look in the tissue. This is why it was so difficult to prove that there was a type 2 inflammation in EOE, and I think it's the same thing in idiopathic hypereosinophilic syndrome. We have to look more and more into the affected tissues, and that's where we have to see what the interactions potentially are between lymphocytes, why not ILC2s as well, and the eosinophils that are found locally. The serum IL-5 levels, for some reason, reflect really poorly what's happening in tissue. Some patients with lymphoid variant hypereosinophilic syndrome and enormous clones don't have increased serum IL-5. Some patients who don't have detectable IL-5 producing T cells anywhere, or certainly not in the blood, do have elevated serum IL-5. So it's clearly not a good biomarker of IL-5 driven hypereosinophilia. I think we really have to look in the right place. That's in the tissue.
Great. So we're at time for our question and answer. There's a lot of very interesting questions in the chat. So if Florence, if you have time,
Sure.
you'll answer those while we move on to our next session. But that was a wonderful talk. Thank you.
Thank you very much.
Okay, I also have the privilege of introducing our next speaker. Dr. Amy Klion is a senior investigator and head of the Human Eosinophil section and deputy chief of the Laboratory of Parasitic Diseases at the NIH. Her research program includes basic and translational research related to the role of the eosinophil and eosinophil activation in disease pathogenesis. The ultimate goal of her laboratory is to develop novel diagnostic tools and treatment approaches for HES and other conditions associated with marked eosinophilia, including Helminth infection. Dr. Klion is a fellow of the American Society of Tropical Medicine and Hygiene and is a recipient of the Society's Bailey K. Ashford Medal. She has served on the editorial boards of Blood and the Journal of Allergy and Clinical Immunology, and numerous advisory committees and expert panels related to her work on eosinophilic disorders and neglected tropical diseases. She is the author of more than 200 scholarly articles, reviews, and textbook chapters. And I also point out that she's also one of my mentors, so it's wonderful to be able to introduce her today. So with that, I'm going to turn it over to Dr. Klion, who's going to talk about HES and its unmet needs.
So thanks, Greg, and I'd like to thank the organizers for allowing me to speak. This is a difficult topic, I find, because so much has happened in the world of hypereosinophilic syndrome over the last number of years. So I'm going to try to give a feel for not just what we still need to do, but also where we've come in the last little bit, so as not to be too depressing and only talk about things that haven't happened yet. I'm waiting to see if I can have, I requested access to advance the slides. Right now I can't advance.
You try requesting once more.
I can. Hold on. Options, request remote control. Okay, I requested again. It worked before.
It did. I will advance for you then. You just let me know when to go
Thank
ahead.
you.
Yep.
So these are my disclosures. I have no financial disclosures, and most of the things that I'm going to talk about are not FDA approved. So I thought I would start with kind of what I view as the landscape of unmet needs. Hypereosinophilic syndromes, as you just heard from Florence, is a very complicated topic, and it has very complicated needs. And I really think that it's the interplay between studies examining the etiology and some of the more recent information, especially that we've gotten from treatment, that allow us to better understand the pathogenesis, the role of eosinophils in homeostatic function, and only by studying all three parts of this triangle are we able to advance. I'm going to focus mostly on diagnosis and treatment, and as you'll see, and I'll mention briefly where we're at in pathogenesis, but for reasons of time, we'll not go into very much detail about that. Next. So this is a graph that was in a study called TREAD, which was a consensus meeting to try and come up with unmet needs that was conducted in 2012. Next. And so, and so you can see, go back. And so you can see in the top, this is from PubMed, and this was published in that TREAD publication, and showed that the publications about eosinophils really started to take off in about 2012. And that was just after the publication of the first successful trials of mepolizumab in asthma. I noticed that the top of that curve was starting to flatten out. And so I did a PubMed search very recently, and this is what I saw. So there was a little blip because of COVID, it turns out, likely because of eosinopenia. But you can see that the number of eosinophil publications when you search eosinophil or eosinophilia continues to increase. And I think that really reflects how far we've come and how many more interesting questions there are. Next. So this was a summary of the Task Force on Research Needs of EADs, or TREAD, in 2012. As I said, the actual table is shown on the right. I don't expect you to be able to read it. I can't, but I've summarized the major headings over on the left. And these were the things that we thought in 2012 were the important unmet needs. I'm going to go through these one at a time and mention kind of what's happened since TREAD and where we are, and then use that as a springboard to talk about where we are, what we need to do next. Next slide. So what about diagnostic codes? So in retread in 2018, which was really an analysis of where we had gotten to by that point, it was recognized that we really didn't have diagnostic codes for anything other than the eosinophilic GI disorders. And so a list was constructed in this table 1 of all the conditions for which we would really want diagnostic codes to be able to know what patients we were studying. Next. Bruce Bachner took these codes on behalf of IES and APFED, the American Partnership for Eosinophilic Disorders, and presented them and were able to get new codes in ICD-10 in 2020, and those are listed below. These actually include most of the major subtypes of systemic hypereosinophilic syndrome, as well as a number of what Florence referred to as the single organ disorders like eosinophilic fasciitis and some of the eosinophilic GI disorders. We're still not completely there, although this is a major step and took a lot of work from a lot of people. Next. As you can see here at the bottom, there was a recent Delphi consensus which looked at the nomenclature for eosinophilic gastrointestinal disease as really just one component and has further subdivided the names of some of those disorders. So I think there's some room to go with our diagnostic codes, but we've made a huge leap since 2012. Next. The second thing that was raised was the issue of biopsy standardization. And here it's really been eosinophilic esophagitis that's taken the lead. Here on the left, you can see from a paper by Margaret Collins in 2017, the development of the EOE-HSS, which is a scoring system that takes into account not only tissue eosinophils, but also the histopathology of tissue sections. And over on the right, the dark bars are untreated and the light bars are treated. And you can see that many of these features improve with treatment. Next. So one of the things that's come into the realm more recently is the use of artificial intelligence and machine learning. This is a paper from 2021 where they looked at nasal polyp tissue and used machine learning to identify eosinophils and other cells in the nasal polyps. And they were able to very nicely differentiate between eosinophilic nasal polyps, neutrophilic nasal polyps, and other nasal polyps. And I think this is really where things are moving. And I've chosen just these two examples, and that's what I'll do for most of the slides. So I'm sorry if I left out important studies or your studies, but time is limited. Next. Laboratory methods, detection of eosinophil granule proteins. This was a major topic of discussion at the TREAD and retread meetings, and really with a focus on looking at human samples other than the blood, in part because blood samples, if they're not collected and spun immediately, eosinophils lyse and granule proteins are released. There was data already to suggest that eosinophil granule proteins in the plasma and serum reflect tissue involvement. And so since 2012, we've come quite a long way. Next. So this is from a paper by Panisse Corey in our group, where we looked at patients with episodic angioedema and eosinophilia. And what you can see is when the patient is asymptomatic is the top panel, when they're symptomatic is the bottom panel. And if you look over on the right at the anti-EPX staining, so this is staining for eosinophil granule proteins, despite the fact that when the patient was symptomatic, we really did not see much in the way of eosinophils themselves, the eosinophil granule proteins were dramatically expressed, and this has been shown in a number of other tissues. Next. There's also been a lot of work looking at non-tissue samples, and here on the right is a paper from Ali et al. In 2022 from Param Nair's group. And you can see that sputum EPX could be detected with an aptamer. The left-hand little bars that you can see are the healthy volunteers, and the bars that are above the threshold line are in the patients who had eosinophilic lung disease. This was adapted into a colorimetric assay, which is shown just below, and the ROC curve looked really beautiful for being able to detect eosinophils in the sputum as a sign of eosinophilic lung involvement. Next. There have also been development of a number of clinical assessment tools. The esophageal string test for diagnosis of eosinophilic esophagitis is a terrific test. We are currently using it in a number of trials. You swallow a capsule that has a string. You let the string sit in the esophagus and part of the stomach for an hour, and then you pull it out, and you can detect eosinophil granule proteins and mediators. And shown at the bottom is the ROC curve, which looked really great for sensitivity and specificity. And on the right is a table showing the difference between the area under the curve using the string test and biopsy. This is a really nice, easy test that can be performed with minimal invasion. Next. Radiographic testing is also advanced pretty dramatically. This is from a paper by Zhu et al. In Rhinology in 2023, looking at radiomics. That's the use of radiology and machine learning. And what they did is they took CT scans of the sinuses and then used some fancy techniques to abstract out data. When they combine that with eosinophils in the peripheral blood, they're able to predict eosinophilic chronic rhinosinusitis with nasal polyps compared to patients that have other types of CRS. And over on the right are the ROC curves for both their initial treatment series as well as their validation series. And again, these look really, really great. Next. And the last example I'm planning to give is a scoring system. So this is mostly clinically based without a lot of special techniques other than a few extra blood tests. And this is a scoring system developed by the French group and published by Stamler et al. This year in JACI in Practice, looking at a scoring system to distinguish between PDGFRA positive and PDGFRA negative tests. And you can see, again, the ROC curves look really beautiful. You might ask, based on Florence's talk, why do you need a scoring system if you have a molecular test? And I would just caution you that molecular tests are not 100%, and particularly the FISH testing, which is commercially available, we know misses about 30% of the patients with this mutation that can be fatal, but is easily treated with imatinib. Next. So what are the ongoing challenges? I've just shown you some of the areas where we've really made dramatic advances since 2012, and I think there are a number of unmet needs. Biopsy standardization is still a problem for most tissues. Consensus eosinophil thresholds, but also looking at other diagnostic features of eosinophilic disease for organs outside of the esophagus and stomach. Invasive and non-invasive tests, I showed you a few. There are many of them that are available. There's very little work on using combinations of tests, and there are some disorders for which there really are not tests. We need tests that can reliably diagnose HES and that can also distinguish between all of the clinical variants, because as Florence pointed out, there may be differences in the therapeutic in the therapies that you might choose depending on the clinical variant. And finally, we need diagnostic algorithms that can accurately and reproducibly classify patients that can be used by people that are not experts in HES. Some of the approaches that we might use, I think we really need to create data and sample repositories that are available to all, that can validate some of the tests that are available, but that also can compare tests to each other. I think that's something that's really difficult to do. Different groups develop different tests, but unless we can combine the tests and look at their reliability compared to each other, I think that that's a huge problem. Next. We need consensus building and guideline development. Diagnostic guidelines, there are many of them that are published in the literature for a variety of these disorders. But again, I think we need to work together to make sure that guidelines for one disorder don't conflict with other disorders, and that we have guidelines for all of the different types of HES that exist. Next. And then finally, we need to incorporate machine learning and AI. That's a very powerful tool that can lead to a lot of garbage, but also some really excellent results. I think we're not using that to the degree that we should be using it at this time, but that's an important approach for the future. Next. Pathogenesis, I'm really not going to spend a lot of time on because that would take 4 or 5 hours. In TRED 2012, we said that one of the unmet needs was a mechanistic understanding of the role of eosinophils in eosinophil-associated disorders. I'm showing here 2 figures from a review that I put together with Steve Ackerman and Bruce Bachner in 2020. And what you can see on the left is some of the things that eosinophils have been proposed to do in homeostasis. On the right is some of the things that they can do when there are too many of them and they cause disease. This is a very complicated process. Next. And so despite substantial progress in our understanding of eosinophil biology and the availability of a wide variety of new tools, including every imaginable kind of mouse with different sorts of defects, as well as all of the fancy molecular tools that we now have, the direct and indirect roles of eosinophils in many eosinophilic disorders remains incompletely understood. And I think this is an extremely important area. There are a lot of unmet needs. And I'll talk a little bit about that at the end. Next. So what about treatment? In TRED 2012, the 2 things that were brought up was improved guidance for clinical trials and expansion of therapeutic options. Next. In ReTRED 2018, the creation of research networks and patient registries was added to the mix of things that were in progress and also needed. Next. So what about clinical trial guidance? We need validated study endpoints. Patient-reported outcomes are available for some disorders. There are many of these that have been approved now, that have been developed and validated for eosinophilic esophagitis, but many disorders don't have validated patient-reported outcomes. Next. In 2020, we tried to develop one of these and did the patient interview part. The large purple bar is fatigue, which was the most common complaint. What we learned was that HES, as we suspected, was very complicated, and patients had a lot of symptoms in almost every organ system, and we were unable to move to the next step of PRO development. Next. In the phase 3 trial of mepolizumab that Florence described, a number of these were developed into a most bothersome symptom score, and that was used as an exploratory endpoint in the trial. This is data from Florence's paper in 2023, showing that in general, this array of symptoms was improved in patients who met the primary endpoint, who responded to drug. That's shown in the top, and that overall, the most bothersome symptoms score improved in all of the domains except skin with mepolizumab, and that really is indicative of what we see in our patients as well. So this looked like a good approach. Next. Around the same time, we had started working together with Evadera to develop a PRO following the FDA guidelines. I know this is too small for you to see the top part of all those gray boxes. This is really just to show you that really developing a PRO in the proper way has many, many steps. Next. And so we went on to develop a PRO, the beginnings of a PRO, relying on most bothersome symptom scores. And this bottom table shows that it correlated very nicely with physician impression of disease, with the PROMIS fatigue score and other scoring systems. So we're not quite there yet, but I think we're on the way to developing patient-reported outcomes in HES. Next. We also clearly need biomarkers that can be used as endpoints. Next. This is data from Dellin et al.'s study published in the New England Journal of Medicine looking at dupilumab in eosinophilic esophagitis. What's shown on the left, it's very small on my screen, so I think what's shown on the left is the histologic score, and that improved on dupilumab, and what's shown on the right is the symptoms, the DSS, which is one of the PROs for EOE, and that improved. Next. But what was really interesting in this study is that they also, in their exploratory endpoints, used two different expression profiling systems developed by the Rothenberg lab, and showed that these also, the Th2 transcriptomic panel in the top and the eosinophil GI panel in the bottom, they were able to show that both of these were improved with therapy. I think that this is really necessary for other diseases and is really in its infancy. Next. In terms of expansion of therapeutic options, Florence went over some of this. This is quite an old figure now. 2022 is already old in therapies, showing what some of the drugs are targeted therapies for eosinophilic disease. Next. Mepolizumab, as Florence mentioned, has already been approved. Benralizumab, I know she wasn't aware, but the data was presented actually at the American Society of Hematology on Saturday. The benralizumab phase 3 study met the primary and all of its secondary endpoints, and so hopefully that will be approved soon for HES. Both drugs are also approved for EGPA and eosinophilic asthma. In the second panel, I'm sorry, so that's mepolizumab. Reslizumab is included in that circle. It's another anti-IL-5 drug, which has not been trialed except in a small phase 2 in HES, but is likely to work in the same way as mepolizumab. Benralizumab is in the second panel. In the third panel, you can see dupilumab, which interferes with eosinophil trafficking to the tissues, although this is proven to have some issues when used to treat patients with very high peripheral eosinophil counts due to elevations in the eosinophil count. It is very useful for some of the organ-specific eosinophilic disease, especially as I showed in EGID, but also in chronic rhinosinusitis. And then in the last panel are some drugs that were in development at the time. Tezepelumab, lebrikizumab, tralokinumab, JAK inhibitors, those are all drugs that are approved for other indications, but have the possibility of working in hypereosinophilic syndrome. Imatinib and nilotinib both work very nicely for PDGFR-A and B, myeloid neoplasms with eosinophilia, and mogamulizumab has been used by the French group for lymphocyte variant HES, and there are a number of other drugs that are available but not likely to be tried in clinical trials for HES. Next. Finally, patient registries and clinical networks. This has really been a wonderful development in our diseases. What you can see over on the right in the box is the rare disease networks, which include one for vasculitis that includes EGPA, and SEGR for the eosinophilic GI research. Right below that, Serio is a French multi-site eosinophil research consortium. To the right is a paper from the Italian network. So there's a French network, an Italian network, and then shown over on the left are all the many PAGs patient advocacy groups that have become involved in these disorders. And these are really important to forwarding all of the things that I've talked about. Next. So what are the ongoing challenges in treatment? As I said, I think we still need validated clinical trial outcome measures for HES in general, but also for many of the rare HES variants, some of which have very restricted symptomatology and really require their own type of outcome measures. We need well-characterized patient populations for treatment studies. Most of these are very rare diseases, and we need treatment algorithms that can be used in clinical practice. Next. So development of patient-reported, clinician-reported, and objective measures of disease activity in accordance with regulatory standards is an approach that I think that we should be pursuing. Next. We should continue to do clinical trials of novel agents, and we should consider doing trials of combination therapies, especially studies that include mechanistic studies, and where possible, directly comparing therapies to each other. As far as I'm aware, the only trial that's done that to date was in EGPA. The trial in HES used mepolizumab, for benralizumab, used mepolizumab as a direct comparator. And then finally, we need sustained development of patient registries and clinical trial networks. Next. So what are the next steps? Well, we had TREAD 2012, which I think was a really useful meeting that brought up the unmet needs for rare eosinophilic disorders. Retread in 2018 reviewed what had been accomplished in TREAD 2012 and brought up some new issues. Next. I think now we need a new tire. Next. We need to reassess unmet needs in the context of the many new tools that are in our armamentarium. We have AI and machine learning. There are novel animal models, selective knockout mice, zebrafish. Non-animal models are starting to be used more and more often, including organoids. And there have been many technical advances in flow cytometry, multi-omics, imaging, and a variety of other domains. And we need to employ all of those in terms of trying to understand where things are at. Next. So thank you, IES. Thank you, Lab of Parasitic Diseases, my home. And thank you all for listening, and I'm happy to take questions.
Thank you, Amy, for that excellent discussion. We're a little bit behind time, and I think we have time maybe for one question. So I'm going to ask one question. In terms of HES treatment, since it's such a heterogeneous disease and there are many subgroups, what do you think are the most kind of unmet needs in terms of the treatment landscape now, given the fact that there's been a lot of advancement, as you pointed out, with different biologics, for example, for HES?
So I think there are a couple of big issues. So one of the problems is that both phase 3 studies enrolled steroid responsive patients. And we know that those trials showed about an 85% response rate in patients, the phase 2 and phase 3 trials. But the patients that are steroid refractory are really a problem. There's very little to do when you have a patient with myeloid HES, with aggressive eosinophilia, even the big guns chemotherapy sometimes doesn't bring their eosinophil counts down. Lymphocyte variant HES can be somewhat resistant to those drugs. So I think those are the difficulties, as well as the disorders where eosinophils may not be the driver of the entire disease, which is why I think we need to be looking at combinations and at drugs that have other mechanisms of action than just depleting eosinophils.
Great, thank you. And as a reminder, feel free to ask questions. We're going to move on to our next talk. Dr. Klion, I'm sure will be happy to answer anything that comes up in the question chat.
Yep.
But thank you very much. I'm going to move on to our next talk. This is by Dr. Anna Kovalszki. Sorry, hopefully I'm not tearing too bad with the pronunciation, but Dr. Kovalszki, oh gosh, Kovalszki, thank you, is an associate professor of medicine and the fellowship program director at the University of Michigan Allergy and Clinical Immunology Division. She began her significant interest in eosinophil-related disorders in earnest while working alongside Peter Weller at Beth Israel Deaconess Medical Center and Harvard Medical School in Boston. She has managed and seen many patients with eosinophilic disorders, and has taken part in clinical trials and participated in research-related endeavors in overall presentation, management, and patient-related outcomes. She has also shared her knowledge in eosinophil-related disorders by giving talks in academic institutions, as well as both national and regional settings. With that, I'm happy to turn it over to Dr. Kovalszki, who will give us a talk on the diagnostic and therapeutic patient journey. Thank you.
Thank you very much for that wonderful introduction. We are switching gears tremendously because I am mainly clinical and I see these patients. And so this is really going to be about sitting back, relaxing, and thinking about what our patients go through and patient journey. Okay. So these are my disclosures. So this is a patient that I have been following for a few years. She has had HES for about 5 years now, and I was part of her journey for almost 2 years now. This is de-identified, but I did share with her that I would like to discuss her case, and she was okay with that. She's a 23-year-old female who was establishing care with me for the management of diagnosed hypereosinophilic syndrome. She began experiencing symptoms 3 years prior to meeting me and has had many evaluations and therapies. She continues to be symptomatic when establishing care with me, with generalized exfoliative dermatitis and erythroderma, covering basically her entire body, significant pruritus, significant fatigue, and myalgias and arthralgias. This is a representative picture of what her rash looked like all over her body when I met her. Her initial presentation, she was undergoing a breast biopsy, which was a benign finding in the end, and around the same time developed some mild lymphadenopathy, transiently more so in the axillae, which she palpated. And in this setting, she developed the rash, the fatigue, and the body pain. She also had temperature dysregulation, feeling cold and with chills, but no frank fevers. However, despite having a history of atopy asthma, she did not have worsening of those symptoms. Her previous history is the above, so she was an atopic individual and also had a history of some issues with her ears as well. Previous medications were very mild and included montelukast, a nasal spray, epinephrine, and albuterol as needed. Positive findings on initial evaluation. She had what I described earlier. She did have a palpable, mildly enlarged axillary nodes. They were mobile and soft. Her nasal turbinates had typical allergy look, but no polyps, and her exam was otherwise unremarkable. However, some of the labs that they received and then went down the path of evaluating for hypereosinophilic syndrome were quite abnormal. Her eosinophil count was in the extreme range, 10,400, and the differential was 54%. And she definitely had elevated white cells and platelets as part of the picture. However, her baseline kidney function, liver function, so on, were normal. She had normal IgG and NEM. However, her IgE level was quite elevated. Tryptase was normal. B12 was normal. We're looking for myeloid variants. Troponin was also normal. And she did have a positive EBV, IgM, and IgG initially, which resolved. She had negative screening for ANCA-positive EGPA, and her other autoimmune labs were normal, and she did not have ESR elevation. EKG was normal, echo was normal, and her CT scan had some abnormalities, so few scattered pulmonary micronodules, and some also in the axillary region, and she also had no hepatosplenomegaly and mild diffuse adenopathy otherwise. Her pulmonary functions were normal. The CT of the sinuses had minimal mucosal thickening and previous history of the mastoidectomy. She was sensitized to tree pollen, grass pollen, and dust mites. After all of this, she had to undergo some biopsies and hematological evaluations as well. So her lymph node biopsy showed reactive follicular hyperplasia. Her sinus biopsy showed no vasculitis or eosinophilic infiltrate, however, had some inflammation and some ulceration. This was done after she'd been on prior steroid therapy. And her bone marrow biopsy did have increased eosinophils, but was otherwise normal. Her TCR gene rearrangements were for a lymphocytic variant were normal. She did not have abnormal T cell populations, and she also had normal markers for myeloid disease. So initially, she was diagnosed with EGPA because of her history of sinus disease and biopsy with ulceration on steroids, asthma, and diffuse symptoms. As Florence pointed out, some of these are overlap phenomena between, and it's hard to distinguish between them. She also was initially followed with a very well-versed rheumatologist. She was treated with prednisone. So although she responded well and she became she had hematological remission, just as Florence pointed out, we cannot always taper the steroids, and that was what happened to her. So she did get one dose of rituximab course, which did not improve her symptoms. She was also started on mepolizumab 300 milligrams, which improved her eosinophilia, but did not improve her symptoms to a large degree. So they decided that they had to try other options to taper her steroids. So this is a classification criteria for EGPA. Once there is a diagnosis of a small or medium vessel vasculitis established, this is not diagnostic criteria for EGPA, but these are the areas that make one consider EGPA more likely. I just wanted to show this, that she definitely had a history of asthma. She had a history of sinus disease, and she had significant eosinophilia and diffuse symptoms. And she was really following these guidelines when she was being treated initially. So she was started on glucocorticosteroids. However, they did not improve her symptoms fully, and she could not taper them. So then she was treated with the rituximab, followed by the mepolizumab addition, and still she could not taper significantly. So her physician felt like she actually had idiopathic hypereosinophilic syndrome in the end, and she was trialed on methotrexate and initially Xolair 150 milligrams monthly, and continued on prednisone. But she continued to have symptoms on that regimen. So I saw her and I explained what I had already seen. She had an elevated white cell count on the corticosteroids, but also monocytosis, granulocytosis, and some eosinophilia. She still had a normal ESR on the meds that she was on, and that was methotrexate, Xolair, and prednisone. And she asked me to do an in vitro PID panel just to make sure she didn't have an underlying disease state, which she did not have. I increased her omalizumab because she felt like it had helped somewhat, but in the end, it really didn't help. And my plan was to try her actually on benralizumab, but I could not get it approved because it's not yet FDA approved. And I tried to taper her steroids, and I referred her to hematology and dermatology. So the outcomes, she did not end up having a repeat bone marrow biopsy, but her pan CT scan was reassuring. Skin biopsy was performed to rule out CTCL, and it was consistent with atopic dermatitis. She got UV light therapy and topical JAK inhibitor, not systemic, neither of which were helpful. And then I could not get benralizumab approved, so I ended up putting her back on mepolizumab after not being able to get omalizumab and mepolizumab approved. I was able to wean her steroid and methotrexate Xolair off, but her symptoms were not fully controlled. So I tried to figure out what else to do, as we do. So mepolizumab did not allow the full prednisone taper. I actually ended up doing what Amy talked about as part of potential future directions of using more than one targeted therapy, not just to lower the eosinophils, but to work on another mechanism since she did have the atopic dermatitis diagnosis, and that was the dual biologic dupilumab for eczema. It was shared decision making. I spoke to her about the possibility of worsening eosinophilia, but given that she was mepolizumab well controlled, we felt it was safe to try to do this. Her prednisone was tapered completely off. She lost 25 pounds and felt significantly improved. Her fatigue improved. Her pruritus and dermatitis and achiness all improved. Her latest CBC shows an eosinophil count of 100. Her other labs are much improved as well. And her latest IgE is 600 from initial in 4,500. So I have some very small area to discuss with you. So biologics in HES, mepolizumab is approved, as you know. Natron, Amy mentioned, had great results. It's going to be approved, I am sure. There was a study done. It was a multinational center of excellence. So all of the speakers today and others on the call were part of this. There were 121 patients included that they had treated historically with different types of biologic agents. So the anti-IL-5s were part of this, omalizumab, dupilumab, and alemtuzumab, which targets lymphocytes. Over 90% on mepolizumab or benralizumab achieved an AAC of less than 1,000. But as we know, the patients may still have symptoms with hematological remission. So then they reported on the different outcomes for the different types of HES. So as you can see, and as the previous speakers mentioned, lymphocytic variant and myeloid, which typically we don't use biologics, these biologics for, are harder to treat and have more red, meaning no clinical response, than the idiopathic variety and EGPA, which actually have a significant response to these agents, even ones that we don't typically use. And the other slide that I really like from this is that you could go up on dosing, you could change, and you could have some improvements that way too. So it's good to be flexible. This is actually a study that Dr. Klion was a part of. It was a retrospective study of different HES subtypes, most commonly those with chronic rhinosinusitis and nasal polyposis treated with dupilumab, and they reported on outcomes. I bring this up because there was a subgroup of patients on anti-IL-5 therapy for HES, but with residual symptoms. They were maintained on anti-IL-5 therapy, and dupilumab was added exactly like what I did in my patient. And none had significant eosinophilia limiting therapy. So this is a busy slide, but I wanted to show you kind of how much this patient went through over time. The eosinophil counts, the different medications, some of which, like methotrexate and prednisone, have significant implications. And where she is now, she's doing quite well. Her facial dermatitis got a little bit worse, so they're using topicals. The dermatologist that follows her along with me mentioned anti-IL-31. We haven't done that. We'll see if it comes to that. So this is her now. She was on active therapies for 5 years, and she had some level of diagnosis for that entire time. In addition, she received invasive tests, as you can see, scans, blood draws, lymph node, sinus, skin, bone marrow biopsies. When I stepped back to prepare for this talk and thought about her as a whole, it really kind of I feel very fortunate to be a part of that journey with her. So the learning points, it's the unclear nature of the inciting stimulus and the reason for HES development in the first place. This is a young atopic woman. She did have, I think, EBV at the beginning of it, though she doesn't have it now. There is at least one paper that I saw linking chronic active EBV potentially with lymphocytic variant HES. I don't know if that was part of it at the start. There's also so eosinophils are part of breast development, and I don't know if the lesions that she had in her breast initially that resolved were part of the picture. Modification of diagnosis to fit clinical picture is really important. Initially, she was felt to have EGPA. Eventually, she was felt to have idiopathic hypereosinophilic syndrome. And targeting new areas within that she feels are not controlled, like her skin disease, are important. The rule of potentially more than one modality to treat and trying still to taper steroids. I didn't tell you this, but her hemoglobin A1C was rising as well. The multi-specialty nature of hypereosinophilic syndrome care, and then it will take time. Even if the diagnosis is there, it will take time to make a difference, but you have to keep trying. And I think you have to be open-minded in all aspects of care. So thank you very much for listening to me.
Great. Thank you for that talk. That was a really excellent portrayal of a very interesting case and presented very nicely. There's one question from Florence. She's asking, was a skin biopsy performed before treatment? So if you could just clarify a little bit more about the findings of the skin biopsy and the time course.
Yeah, so the skin biopsy was performed when she was already on prednisone and Xolair. It was performed by me. But she had stopped her methotrexate, and I had tried to wean down her steroids to the lowest possible dose when they did that.
I had a quick.
Yeah.
Oh, sorry.
No, it's fine.
I also wanted to ask a question, if that's okay. In terms of, so it sounds like the dupilumab obviously made a very big impact in terms of her symptoms, and when the anti-IL-5 biologic mepolizumab didn't really do much, nor the Xolair. She still remains on dual biologic. Have you thought about or discussed maybe with the patient considering either weaning the mepolizumab or potentially coming off of that in the future? What's your plan or thoughts on that?
Yeah, so I have not been comfortable to do that yet, and she was okay with it. It will come to a head at some point, I think, especially in terms of how much the cost is. It may be an option for the future. Before I did that, I was actually going to discuss her case with other experts.
I see Amy has her hand up. Yeah, go ahead, Amy.
Yes, Amy.
Yeah, so I was going to respond to that. So the paper that you cited that we did with Walter Reed, so the problem was that the patients who were put on dupilumab alone, there was a high incidence of dramatic eosinophilia and some really significant eosinophilic complications in the people put on dupilumab alone. The people on duals, nothing happened to them. There were no complications. We have taken some of those patients off. If you off their eosinophil lowering biologic and left them on dupilumab, when you do that, the eosinophil count rises. In some patients, it's risen back to the level that it was at before. But so far, we haven't done that in patients with life-threatening disease, and their symptoms have not come back, and we've been able to maintain them on dupilumab alone. We do have an ongoing clinical trial for those of you in the US to add dupilumab therapy onto an eosinophil lowering biologic for patients who have residual symptoms. We're able to provide the dupilumab. So feel free to contact me if you have patients. We're enrolling now.
Dr. Gleich?
I should share an experience with a patient who had clear-cut eosinophilic granulomatosis with polyangiitis, with a life-threatening disease, treated with prednisone, and then later switched, when time permitted, to mepolizumab, and then to benralizumab. And then, because this patient had a severe perforated eardrum with chronic ear discharge, Dupixent was tried. And with the combination Dupixent and benralizumab, the patient did quite well. And gradually, as she improved, benralizumab was stopped. The patient's only on dupilumab now. She recently became pregnant while on dupilumab and is carrying the pregnancy quite nicely. So this experience seems to dovetail with what Amy was just describing, is that some of these patients do quite nicely on dupilumab only after the acute manifestations are treated?
So I should be more willing to try it, is what you're saying. And Florence put also that often where there are dual treatments, it seems that the second one that works and the physicians forget to remove the first. I didn't forget, I just wasn't cavalier enough. But maybe I will be as these new developments come up.
I wasn't suggesting that, Anna.
Harold Wilson Morkey has a comment. He says another example that that these are complex heterogeneous diseases that will often not achieve sustained remission with single agents, that bispecific and perhaps trispecific biologics maybe are required in this space and their safety prospectively assessed. So he's excited to hear about that study that Amy had mentioned. Steve Ackerman also asked, do current treatment approaches, biologics, and protocols result in very little evidence or development of cardiac involvement with progression to myocardial fibrosis in HES patients?
So I will tell you what I know clinically, and that is that the patients I have treated with biologics either improved on them significantly enough that I could just use one biologic, one of the anti-IL-5s. I have never had anyone have myocardial disease after they were already on treatment. And I think on my end, I think the reason is that we monitor them carefully, to be honest with you. We look for it all the time. We look at troponins and so on if they have any symptoms whatsoever, and also eosinophil counts.
Wonderful. So I think we're at time. That was an excellent discussion and presentation. Thank you, Dr. Kovalszki, for that. I'm going to pass it on to my co-moderator, Dr. Gleich, who's going to finish us out here with some closing remarks. Thank you.
Well, I'd like to thank everyone for these provocative and excellent presentations. It's clear we have a ways to go, and I think the case which Dr. Kovalszki presented was illustrative of some of the complexities that one appreciates in treating these patients in clinical practice. I'd like to make a couple of other comments. I emphasized earlier, those of you who have listened to the presentations can join the AES, and one of the slides earlier had an entry. I want to draw your attention to the upcoming meeting in July of 2027, 12th to 16th in beautiful Vancouver. And at that presentation, we will learn about, I'm sure, very many things, but to go ahead in January, the 14th specifically, we will have another webinar which will take up roles of eosinophils and mast cells in infection and stress, and probably will be a useful comment, a series of comments and knowledge about patients like the one that Dr. Kovalszki presented. I'm assuming the slides will become available on our website of the IES. Can one of my assistants perhaps comment on that? Is that correct?
Yeah, the recordings will be available on YouTube in the next few days in English, Japanese, and German.
And the slides will be available as part of that, again, I assume. And last but not least, I'd like to thank AstraZeneca for their support. The information that Dr. Roufosse and Dr. Klion presented about the study of benralizumab sounds very encouraging, that this drug will become available. And it could be a very useful armamentarium, a contribution to our armamentarium. I think I can pause there and ask Dr. Constantine if he has any other comments to conclude.
Oh, thank you. Just once again, just reminding everybody that this is the video for today's webinar. Thank you for joining. Will be available on YouTube shortly in a few days after today's webinar presentation. and it's been recorded both in English, German, and Japanese. And we'd like to thank AstraZeneca for sponsoring today's webinar, and thank you to everyone for joining us today.
Thank you again.
Bye-bye.
Goodbye.
Goodbye, everyone.